sleep medicine at Some Ultimate Medicare Hospital, Bhubaneswar. Welcome, Dr. Alisha. Over to you.
Thank you very much for the introduction. I thank ISCCM also for giving me this opportunity to talk on this topic. It's a very important topic, I'm sure, for all the people over here, because I think that is one of our go-to drugs after antibiotics every time an emergency occurs in ICU. So most of the time you would have heard in ICU your doctor telling, yes, patient is in shock. So what does he actually mean? It's meaning that, if either the oxygen delivery is not happening, or the oxygen is not getting utilized properly. And how do you see that shock in that patient? You look for clinical signs. You'll see the doctors looking at ABGs. You'll see like peripheries, whether they are warm or cold, presence of hypotension, which can be there or not there. And also we look at urine output. So these are all the markers to see that basically tissue hypoperfusion is like it has occurred. So then what do you do with your doctor or your clinical team? You treat the cause, you give some fluids. And there's one drug which I have mentioned over here which you actually vasoactives. Like the drugs we'll be talking about today. So this is a very simple slide basically to talk to you about the fact that in our body, this is a rough diagram. Okay, so this is the heart, this is our circulatory system, this is the heart. I hope you can understand it's a brain, this is the liver, and this is the kidney. So we know the heart pumps, blood flows, and branches out and gets delivered to all the end organs. So that is how a circulatory system usually functions. There are a lot of auto-regulatory mechanisms which which take care of this blood flow and make sure that this perfusion is happening and all end organs are getting perfused. And this is the sphygmanometer which you normally use, which you measure it, NIBP, you measure it at the hand. It is quite upstream. So the purpose of this diagram was to tell you that what are these auto-regulatory mechanisms in the body which is taking care of this blood pressure which you keep measuring at the bedside. So at somewhere in these vessels near the end organs, the peripheral vessels, you have some, So you have over here alpha-1 receptors. Okay, so these are in the peripheral blood vessels. You'll have alpha-1 receptors. Now, what is the importance of these alpha-1 receptors is they vasoconstrict. That means they narrow down. So that is the only thing they do, right? Because of which what happens? Back pressure is created and the blood pressure increases. Anything which narrows down and fluid flows through it, pressure increases. So that is why blood pressure increases. And this alpha-1 actually causes a global vasoconstriction-like state, which makes sure like if a blood pressure goes down for any reason, this is going to help over there. But this comes at a cost. So if the blood vessels are going to get narrowed over here, then definitely your end organs perfusion will be impaired. So at that time, there is another thing which helps over there are the beta-2 receptors. So beta-2 receptors you can get in your airway muscles also, but you get also in your vascular endothelium. What do these beta-2 do? They do the absolute opposite of alpha-1, that is smooth muscle relaxation, and they cause vasodilatation, making sure that all the end organs are perfused. But the sole purpose of alpha-1 increasing the blood pressure will now be lost because beta-2 will cause vasodilatation and there is a drop in the blood pressure. Another important receptor which we should know about in the heart is actually over here is your beta-1 receptor. Why this is important is these beta-1 receptors increase your heart rate and contractility, what we also call as your inotropic and chronotropic action. So better pumping of the heart, more forward blood flow, better cardiac output. So if you see, actually these auto-regulatory mechanisms are actually an interplay of all these receptors. So that is why I just wanted to give you a fair idea about where these receptors are located and what do they do. So we talked about alpha-1. The alpha-1, let's see. So the alpha-1 is in the vascular endothelium and that causes vasoconstriction. We talked about beta receptors. Beta-1 is in the heart, which causes increased contraction and heart rate, both inotropic and chronotropic action. And the beta-2 is at the level of the vascular endothelium and even the airway also we find, which causes vasodilatation and airway smooth muscle relaxation. And there's one more other receptor, dopamine, because that is also one of the drugs used in the ICU, DA1 receptor, which is present in the peripheral blood vessels, renal, splanchnic, coronary, and cerebral blood vessels, causing vasodilatation. Now, this beta-1 actually has receptors. They promote a positive inotropic, chronotropic, and even dromotropic action. Dromotropic action is nothing but increased rate of conduction through the AV node in the heart. So these beta-1 receptors are very important in the heart. I cannot, and the top part is not seen. Okay. So the point of putting this slide was that apart from your usual alpha and beta and DA1, we have alpha 2 and beta 3. Alpha 2 is not much used when we talk about vasopressors and inotropes. Beta 3 will be definitely of use when we are reading about adrenaline. I'll be mentioning over there. Just remember, beta 3 is in the adipose tissue and stimulation of that receptor causes increased lipolysis. Now, what do you mean by vasopressors? Vaso meaning vessels, pressors meaning press on the vessels, right? So that causes vasoconstriction, and that increases your systemic vascular resistance and the mean arterial pressure. That is what I showed, right? Alpha receptors in the blood vessels, narrowing of the blood vessels, vasoconstriction, and increase in the blood pressure. Now, inotropes, when we talk about inotropes, they increase cardiac contractility. That is why the beta-1 action, when I was mentioning the beta-1 receptor, inotropic and chronotropic action. So inotropes, when we are mentioning the word inotropes, those drugs basically increase cardiac contractility, improve the effective functioning of the heart. But most of the drugs we have at present with us, vasoactive, whether vasopressors or inotropes, have both the effects. Something may be strong, something may be weak. That we'll be seeing in the further presentation. Now, this is a rough classification. This is a rough classification of all the vasopressors and inotropes we know. The point of putting this was that if you look at these there are drugs like inoconstrictors, inodilators, vasodilators, and vasoconstrictors. We think that noradrenaline, epinephrine, and all increase blood pressure, which is true, right? But they also have some cardiac stimulant activity. So to call them as pure vasopressors will be wrong, because these three drugs, they will increase the systemic vascular resistance, but because they stimulate the cardiac contractility, inoconstrictors is a better name. Similarly, when we look at dobutamine, milrinone, and levosimendan, they are known to be called as vasodilators. But are they pure vasodilators? No. They reduce the systemic vascular resistance, stimulating the cardiac contractility. That's why they are called as inodilators. So, if some drug has both alpha and beta action, if the alpha action is more pronounced than the beta, it is an inoconstrictor like norepinephrine, epinephrine, and dopamine. If beta action is more pronounced than the alpha receptor action, it is a inodilator like dobutamine, milrinone, and levosimendan. The only pure vasoconstrictors are rather phenylephrine, vasopressin, and angiotensin, because they don't have any action on the cardiac per se. Now, this is a different mechanism of action. Whenever the beta, you give any vasopressor or inotrope, which is a beta agonist, it acts on the beta receptor, and through cyclic AMP production, we get the positive chronotropy action, positive inotropy, and vasodilatation. Similarly, an alpha agonist acting on the alpha 1 receptor in the place I mentioned, phospholipase C mediated, they lead to vasoconstriction. So what are the indications of all these drugs? Is different types of shock in cardiac arrest situation, especially in your ACLS protocol you would have come across, and even post-procedure hypotension. The different class of drugs what we have among the vasopressor and inotropes are catecholamines, endogenous catecholamines like dopamine, noradrenaline, adrenaline, and synthetic like dobutamine, isoprenaline, and phenylephrine. There are other sympathomimetic drugs like metrominol, other hormones like endogenous vasopressin and synthetic is terlipressin is what we see. Phosphodiesterase inhibitor like milrinone, and calcium ion sensitizer levosimendan. Now coming to the vasopressor pharmacology, the purpose of this slide is to tell you that when you look at isoprenaline as a drug, it has a profound beta action, hardly any alpha action. But as you go down to dobutamine, dopamine, you will see that they have both alpha and beta action. And when you are going to phenylephrine, it has a pronounced alpha action and hardly any beta action. That is why isoprenaline is a pure beta agonist and phenylephrine is a pure alpha agonist. Rest all of the drugs over here have some amount of alpha and beta actions. Now coming to noradrenaline. So noradrenaline, if you look at here, that the beta 1 action is only 2+. Look at the alpha 1 action of noradrenaline, which we use commonly in the ICU. It is so pronounced, almost 4+. Beta 1 action is just 2+, and beta 2 is 1+. So as we discussed, alpha 1 is in the blood vessels. So action is more pronounced, that meaning more increase in systemic vascular resistance, which leads to more increase in systolic blood pressure and diastolic blood pressure. But the beta 1 action is just mildly raised. That is why not much change in cardiac output, and even the rate of heart rate increase is also not very high. It is very minimal increase. Beta 2 is even weaker, because beta 2 causes vasodilatation. So even like most weak action of beta 2, that will only actually help you to use this drug in an emergency situation when you want the blood pressure to rise. Now, initially, if you notice, when you start noradrenaline, sometimes there can be a decrease in the heart rate, which is against the fact what I told, because it has beta 1 action, there should be actually increase in the heart rate. But there's decrease in the heart rate. So this happens because of the baroreceptor reflex. What is the baroreceptor reflex? So when the blood pressure increases, the afferent impulses reach to the cardiac, they get a signal that the blood pressure is fine, blood flow is okay. So the parasympathetic nervous system takes over and the heart rate is reduced because blood pressure is increased. So heart doesn't need to now pump or exert more. So that is what happens initially when you start with low doses of noradrenaline. But later on, once the dose keeps increasing, this reflex is lost and worsening tachycardia can occur at really high doses because of this beta 1 stimulation. And this is really bad because somebody who's in cardiac failure, if you keep on increasing the systemic vascular resistance, the heart has to pump against even a very high pressure. So that is very bad in cardiac cases. The dose of noradrenaline we commonly use is around 0.01 to 2 mics per kg per minute. So where do we use this noradrenaline drug? Useful in septic shock, neurogenic shock, cardiogenic shock. I've just left out anaphylactic shock, which I'll be telling later. So all these kind of shocks, we have used this. Even in hypovolemic shock also, you use noradrenaline as the first choice of vasopressor. When especially hypotension is there, that is the most important point. Second indication I've written is cirrhosis with hepatorenal syndrome. Why did I mention this over here? That as we read already, alpha 1 in the blood vessels causing vasoconstriction. So in a cirrhosis patient, there is already splanchnic vasodilatation. So this will help in that cirrhosis cases causing splanchnic vasoconstriction and improve the blood supply to the kidney. So even you can use your NORAD in this condition. So any dose of noradrenaline more than 0.5 to 1 mg per kg per minute are really considered high. But if you ask what is the maximum NORAD dose for a refractory shock, there is no such defined dose. Every institute has a separate protocol of diluting it and titrating it. So advisable would be to follow your ICU or your institute's protocol. So if I tell in nutshell about noradrenaline, it is the first line vasopressor in sepsis and other kind of shocks, especially when the patient is in hypotension. If you are using a peripheral IV line, it is okay. You can use in low doses, but higher doses, it is better to put a central access. In high cardiac output states meaning like the case of sepsis itself, where the demand is very high. In those cases also, it's a very good first line vasopressor. Now, what are the disadvantages of noradrenaline? Is its cost, bradycardia, but it is not present with higher doses. The reason for bradycardia I already mentioned. It can worsen cardiac output, especially in patients who are already with a compromised heart. As I mentioned, increased systemic vascular resistance, increased afterload, heart has to pump against a really high pressure. It can lead to visceral ischemia, And peripheral even extravasation can also cause some, peripheral extravasation can also cause necrosis and gangrenous changes. So we have to be careful. And sometimes you may need addition of inotrope because you're giving so much of alpha-1 action, you need some beta-1 action depending on the indication actually. Now coming to epinephrine. Now epinephrine, if you look at, it has a very good profound action on the beta-1 receptor. So it's a good, has good inotropic and chronotropic action. On alpha-1, it is in the mid-range, so it does cause some vasoconstriction also. And beta-2 action is minimal compared to the beta-1 alpha-1, so less vasodilatation. So it is one of the drugs like related to noradrenaline, but it has actually a good action on the heart, along with it also raises the systemic vascular resistance and increases the blood pressure. So both the cardiac action and a peripheral action also. At the doses of 2 to 10 mics per minute, it is actually predominant beta-1 action, that is inotropic with a mild vasopressor. Once you cross more than 10 mics per minute, it has predominant vasopressor action, which is alpha-1 action. So these are very important things you should know what you are targeting at when you are starting this drug in the patient. So adrenaline, the net effect after understanding, going through all these receptors is because of alpha-1 action, there will be increased systemic vascular resistance and increased blood pressure. Because of beta-1 action, you have a good cardiac output and increase in heart rate. Now, what are the concerns with adrenaline is that there will be increased blood lactate levels. Now comes the role of beta-3 receptors, which I had mentioned over there, which is present in adipose tissue. So beta-3, when it acts on beta-3 receptors, increase lipolysis, metabolism, and then leads to increased blood lactate levels. It decreases Planck blood flow, same thing because of vasoconstriction. So increased risk of ischemia. Adrenaline is actually, or epinephrine is actually the drug of choice in cases of anaphylactic shock. When it comes to septic shock, it may be a secondary agent, or in patients with hypotension with the existing cardiac condition, you can think in those patients as adrenaline as the first drug. And in case of cardiac arrest, as per ACLS protocol, we are using it. Doses more than 0.3 to 0.5 mics per kg per minute are considered very high. Again, the same thing, there is no defined dose of maximum epinephrine for a refractory shock. But if you, for all other maybe shocks, if we take noradrenaline, for anaphylactic, the drug of choice is epinephrine. I think 0.5 mg IMV give. So in a nutshell about epinephrine, if you have myocardial dysfunction, it will be a first option. It is a cheaper option. Even though lactic acidosis occur, it's not life-threatening, it is usually transient. You may require really high doses for severe vasodilatation, and because it increases the heart rate and cardiac contractility also, it may increase the myocardial oxygen demand. Now coming to dopamine. So dopamine, if you see if you look at the receptor actions over here, apart from the DA1 and DA2 receptors, you see dopamine has a mid-range action on all beta-1, alpha-1 and beta-2. So similarly like adrenaline, it also acts both on the heart and peripheries, but as profound as adrenaline has on heart and peripheries, this has a medium range action in all the three receptors. And as we know, dopamine is an immediate precursor of norepinephrine and epinephrine in the catecholamines pathway. And dose-dependent effects are very important because at the dose of less than 5 mics per kg per minute, dopamine stimulates the DA1 and DA2 receptors. And as I mentioned, DA1 is present in your renal, mesenteric, and coronary beds, so that's why it can cause vasodilatation there. At the dose of 5 to 10 mics per kg per minute, a weak beta-1 effect and weak alpha-1. Beta-1 we already know will increase heart rate and contractility, and a weak alpha-1 with a mild increase in systemic vascular resistance. But once you cross the dose of more than 10 mics per kg per minute, it is predominant alpha-1 and beta-1 action. Now, problem with dopamine is there can be a marked variability in the clearance rates, especially in critically ill patients. So the plasma concentration are very vary, and it is an inotrope in a lower doses, but vasopressor in really higher doses. So you can again use them in septic, cardiogenic, and neurogenic shock. As I mentioned, so it is a vasopressor which can be used even with the peripheral IV. If you want an increased heart rate because of its beta-1 action, many people are familiar, most of the cardiologists still advocate dopamine. But the thing about that at lower doses, because we read about renal vasodilatation, that it has renal protection, has been refuted. There is no such thing that low dose dopamine promotes renal protection. Rather, the downsides are it can lead to tachycardia, catecholamine depletion, again visceral ischemia because of vasoconstriction, and some amount of immunomodulation. Now coming to our next drug. After noradrenaline, whenever the BP doesn't pick up, you hear your doctor saying, where is vasopressin? Immediately started. Now, if you look at vasopressin, it comes from your hypothalamus to stored in the posterior pituitary. It is released from there and it then acts on two receptors, V1 and V2. So the V1 receptor is there in the blood vessels. It will constrict those blood vessels. It will constrict the blood vessels and increase the systemic vascular resistance, just like what happens with the alpha 1. But this is through V1. And the V2 receptors is present in the kidneys. So that will help for your water reabsorption, fluid reabsorption. So increase blood volume. So through both of these mechanisms, vasopressin promotes an increased arterial pressure. So if you're looking at this mechanism chart, it is now clear to you, it has no action on alpha or beta 1 or beta 2. It is purely vasopressin receptors V1 and V2 mediated. So that is what I have mentioned. No role in no effect on the heart. In the vasculature, 4+ like, as in almost like how an alpha 1 can lead to vasoconstriction, that potent it is. And in the renal, V2, water retention. So the net effects will be increase in systemic vascular resistance, so increase blood pressure. Definitely the systemic vascular resistance increase with vasopressin is so high that the afterload is so high that actually it can even reduce cardiac output and decrease coronary blood flow. And among all the vasoconstrictors, vasopressin is the most potent vasoconstrictor. That is why when the NORAD doses are tapering, you might have heard from a doctor saying that try to come down on the vasopressin also fast. It also reduces pulmonary vascular resistance, vasopressin, and favors that though it increases systemic vascular, it reduces pulmonary vascular. This is because through this V1 mediated receptor in the pulmonary endothelium, nitric oxide is released, which causes vasodilatation. That is why in case of pulmonary hypertension, if you want to start a vasopressor, vasopressin is a good drug. It's also useful in septic shock as a second line, as we already know. And the vasoconstrictor effect is retained in hypoxia and acidosis, because in such cases, the alpha 1 receptor agonism becomes less effective. So in those cases, it will be very helpful to maintain the vasoconstrictor effect. Also in septic shock, as we know that there is relative vasopressin deficiency. So to come down on the catecholamine requirements, that is NORAD and adrenaline, vasopressin will be really helpful. But since it's a very potent vasoconstrictor, we have to be careful about the part that because of this vasoconstriction, it can lead to a lot of visceral ischemia again. So it is not a first line vasopressor. If your NORAD doses are going more than 0.3 mics per kg per minute, you can use this as a supplement then. Replacement doses are 0.02 min per minute or 0.04 per units per minute. There's no upward titration of dose. Once you have started vasopressin, you may need to also add steroids. Now, tapering of vasopressin is a different school of thought everywhere. Though initial guidelines mentioned you don't need to taper down, you can just stop at the dose advised. But different institutes, again, some institutes do try to taper and stop vasopressin, but as such, there is no data for that. Now coming to phenylephrine. If you remember that spectrum of the vasopressors and inotropes I showed, phenylephrine was at the bottommost. So if you can see from here, it has a pure alpha action. No beta 1, no beta 2. That means no action on the heart, only on the periphery. So it's pure alpha 1 receptor agonist without any beta 1 or beta 2 receptor activity. So the advantages is it has like shorter duration of action, primary vascular effects. It's very useful in cases of neurogenic shock or hypotension during anesthesia, where you just want to give some bolus dosing. Bolus dosing is at 0.1 to 0.5 mg every 10 minutes. And infusion, if you want to start, it is 0.5 to 2 mics per kg per minute. But the concern is increased afterload for the heart. It can worsen the cardiac output, and there is very limited data about it. So Basically, it is also called as a push dose vasopressor because you're giving it as a bolus dosing. So since I have mentioned, we spoke about adrenaline, we spoke about noradrenaline, we spoke about dopamine and phenylephrine. Now we are confused, right? When do we use what? So whenever you're using vasopressors, our MAP goal is more than 65, but you need to individualize needs because based on the underlying clinical condition. Norepinephrine or dopamine as the first choice based on the SOAP2 trial, but actually norepinephrine is preferred. That is what the guidelines say. Though epinephrine is cheap, it has risk of anaphylaxis, myocardial dysfunction can be present. You can have transient increase in lactates. And phenylephrine or vasopressin should not be used as first line. And if you are using vasopressin, use it only in addition to norepinephrine. And there is strictly no renal dose of dopamine. Now coming to dobutamine. So now we are going towards the inotropes part. So if you look at dobutamine, look at the action of dobutamine on beta 1 and beta 2. Very strong action on beta 1. As we know, beta 1 was in the heart, so increase inotropy and chronotropy. It has mild beta 2 and alpha 1 action, but alpha 1 action is the weakest. So based on the table on the right and top side, so beta 1 is to beta 2 action of dobutamine is actually 3:1. So beta 1 action is more profound. It's more of inotropic than chronotropic also. Beta 1 stimulation augments myocardial contractility. There is moderate beta 2 receptor agonism, as I have written, and very mild alpha 1 agonism. So there can be some peripheral vasodilatation because of the beta 2 action. So net effect, whatever on the map you are seeing, it will be based on the changes of cardiac output and systemic vascular resistance. So that is how you will titrate your dobutamine. You look at the cardiac output, you look at other clinical markers, and then decide how do you titrate the dobutamine. So dobutamine also, almost like dopamine, you have to remember that at less than 5 mics per kg per minute, it has predominant beta 2, so causes profound vasodilation. At 5 to 15 mics per kg per minute, it's predominantly beta 1. So increased heart rate, increased contractility, very weak alpha 1 and beta 2 effect. But at 15 mics per kg per minute, the alpha 1 action slightly becomes stronger. Since the inotropic and chronotropic action, because increased heart rate is this thing along with the contractility, there can be increased myocardial oxygen consumption. And do not look at only the blood pressure for dobutamine because the effect is variable. You need to look at the other clinical markers. Like usually we start dobutamine when we feel that we need vasodilatation, the peripheral end organs are not getting perfused. So for kidney, like we see urine output, for liver it is lactate. For brain, look at the sensorium. So look at all those things along with the blood pressure to titrate the dose of dobutamine. It's useful in cardiogenic shock and sometimes in septic shock especially if you feel that it's acutely unstable patients in cardiogenic shock because of its short half-life and you just want some improvement in cardiac output. So in those cases, you can add this. And it will work more better if you have already the intravascular volume is normal. If the patient is volume depleted, then this may not help, right? At that time, you have to think of adding this drug with the noradrenaline. Okay, only if you have a good volume status and even then your end organ functions are not improving, then you can add dobutamine with the noradrenaline. Now, the next inotrope we need to talk about is milrinone. So milrinone, the thing with milrinone is that whenever a beta 1, beta 2 stimulation receptor, beta agonist comes and acts on the beta receptor, it leads to increased cyclic AMP production. This cyclic AMP is actually broken down by a phosphodiesterase inhibitor. So this phosphodiesterase enzyme, PDE3 enzyme. Milrinone is nothing but it is going to come and inhibit this action of this phosphodiesterase enzyme. So this cyclic AMP breakdown, which is happening by phosphodiesterase, will be inhibited by milrinone. That is how it exerts its inotropic effect. So net effect is an increased inotropic effect. There is potent systemic vasodilatation. So systemic vascular resistance decreases, afterload is reduced, and preload is reduced. Now, milrinone, comparatively, if you see the myocardial oxygen requirement, because it does not directly exert effect on the heart, I mean, the inotropic action, it improves, not as such the chronotropic action. The myocardial oxygen requirement is not that much. And the loading dose is around 50 mics per kg over 10 to 30 minutes. And infusion is 0.375 to 0.75 mics per kg per minute. So, it is also known to be very good for, apart from the peripheral vasodilation, it also works for pulmonary vasodilation. Same way how your PD inhibitors are used for pulmonary hypertension. That is why in cases of RV failure, it's a good option to be used. The adverse effects only with milrinone is that compared to dopamine, this tachycardia problem is not there. That is one thing is good, but the problem is that in renal failure, you need to adjust the doses. And the half-life of milrinone is quite long. So once you even stop milrinone because patient has developed hypotension, for its effect to wear off takes really long time. So hypotension is prolonged, whereas with dobutamine, it's a very short half-life. So the effect may be very short-lived. Those are the two only issues with milrinone. And it's more actually useful in cases of chronic heart failure also, where the beta-1 receptors are already desensitized and down-regulated. In those cases, this milrinone does better because it will be inhibiting the phosphodiesterase breakdown of the cyclic AMP. Now, dobutamine versus milrinone. So, dobutamine is mainly recommended for patients with hypotension, especially like cardiogenic shock and septic shock cases who already have myocardial dysfunction, or in cases of severe renal failure, because we read milrinone will accumulate. Whereas milrinone is preferred for patients with chronic heart failure, especially who have more of RV failure component, or patients are on beta blocker therapy, because we are worried with beta blocker therapy because already beta receptor desensitization must have happened, or if there is pulmonary hypertension because it is phosphodiesterase inhibitor. So we should know when to use dobutamine and when to use milrinone. The other inotropes we know in ICU may not be very, you may not be using on a regular basis, but just for knowledge basis, you should know is levosimendan. So levosimendan is actually a calcium sensitizer. So it sensitizes the myocardium to the existing calcium. So due to which the contraction is better. So that is the inotropy. Through potassium mediated channel activation, it causes vasodilatation. So that is why levosimendan is also a good option, but again, same issues, it can lead to hypotension. So we need to be careful where we start levosimendan. These are all drugs more useful in your cardiac cases or heart failure cases where you can actually think of adding up these drugs. So levosimendan dose is around 0.1 to 0.4 mics per kg per minute. And one more drug is isoprostol or isoprenaline. So isoprenaline, you must have all heard that most of the times that heart rate is low, so start off isoprenaline. So actually isoprenaline, what we saw in that spectrum, it is actually a pure beta action, right? There is no alpha action at all. Beta, it is non-selective as in this, non-selective as in the sense it acts both on beta-1 and beta-2. So it is a potent non-selective synthetic beta-adrenergic agonist. And it has both chronotropic and inotropic properties. That is why the increase in heart rate and some systemic and mild, potent systemic, but very mild pulmonary vasodilatory effects. That's why it is an inodilator. Usually you would have seen it in the case of bradyarrhythmias, you would have been advised for isoprenaline. So the dose is around 1 to 4 micrograms per minute given by intravenous infusion. This is just for your this thing that I know isoprenaline and levosimendan you should just be aware of, but dobutamine and milrinone are really important. So coming to the bottom line with inotropes, you use it when especially there is a cardiac condition, some myocardial dysfunction is happening, patient is in failure, then these drugs come into action. Only if you have a stable blood pressure, patient's volume status is fine, despite that your peripheries are, when your end organs are not getting perfused, you need to then vasodilate them. That is why you think of these drugs, dobutamine and milrinone. So if only you have a stable blood pressure, you add dobutamine. Milrinone would be very good if you have an associated RV failure also. So that way, milrinone would be a better drug. Otherwise, in case of renal failure and because of its prolonged hypotension, sometimes it is not advocated. The caution with milrinone, as I mentioned, long half-life and dose adjustment with renal failure. Now, complications of giving these vasopressors and inotropes, what are the complications? When you use catecholamines like dopamine, adrenaline, noradrenaline, they can all cause significant tachycardia in volume-depleted patients and can even lead to tachyarrhythmia. So that was a very common thing seen with dopamine and sometimes even with adrenaline. But that's why dopamine has like slowly gone out of the ICU. You hardly see in medical ICUs nowadays dopamine being used because of the risk of tachyarrhythmias. And when you're using catecholamines and vasopressin together, if you remember, the catecholamines have a good alpha-1 action, and vasopressin, though it acted on V1, the rise in systemic vascular resistance was more profound than even the alpha-1. So that leads to a higher afterload. The heart has to pump. An already compromised heart, which has to pump against such high afterload, patient can go into MI. So you need to be careful. When you have a myocardial dysfunction with excessive vasoconstriction, again, the issue what can happen with catecholamines, you can have decreased stroke volume, cardiac output will reduce and reduce oxygen delivery. The other issues with vasopressors is you can develop limb ischemia and necrosis, especially extravasation when it happens. It can cause splanchnic vasoconstriction. So splanchnic vasoconstriction only in the case of cirrhosis, where actually splanchnic vasodilatation is there. When splanchnic vasoconstriction happened, it was beneficial. But in other cases of septic shock or cardiogenic shock, very high doses of vasopressors also can reduce splanchnic blood flow, and that can lead to visceral ischemia, what I was mentioning, that was stress ulceration, malabsorption, bowel infarction. And other phosphodiesterase inhibitors and levosimendan, like milrinone phosphodiesterase inhibitor, what we spoke about, can cause profound hypotension. This will happen if the patient's volume status was not adequate and you have started this, right? So compared to dobutamine, milrinone and levosimendan cause even more profound hypotension. So this is a brief table about the dosing of all the vasopressors, where we have mentioned about at what initial dose you are going to start, what dose range you are going to target and monitor the vasopressors. Every 5 to 15 minutes, we cannot just start the vasopressor and walk away from the patient. You need to stand next to the patient initially while starting, whether the patient is tolerating it well or not, any issues with the line. And every at least 5 to 15 minutes, you need to come back and see that whatever goal has been set in the ICU by your doctor or by your consultant, everyone, your team discussion, has it been met or not? You look at the other clinical markers to see whether there is an improvement or not. And once your target has been achieved, based on the patient response, you start weaning. Okay. So this is a good paper in case if you are interested, which tells that what tips you can take to optimize when you're using, especially vasopressors in hypotension. You have to have a set goal of blood pressure. What is your mean arterial pressure? What is your diastolic blood pressure? Individualize your BP goals. If it is a traumatic brain injury patient, your blood pressure goal will be different. If it is a plain hypovolemic shock because of some peripheral trauma, like for example, crush injury or something, then your goals will be different. And if it is septic shock, again, your goals will be different. So you have clear goals based on the case and the patient's requirement. Always reassess clinical status regularly and bedside markers of cardiac output, right? Especially when you're using inotropes, you just can't look at the blood pressure and stop over there. You need to, because you're vasodilating, you're improving the blood flow to end organs. So you need to see bedside markers of cardiac output through an echo. You can see, the cardiologist can see, or your doctor can see, or at least what you can look at it. What is the lactate level? How's the urine output? What is the sensorium? All these things. And the blood pressure when you have initiated a vasopressor. In case one of the agents is not working or some issue, patient is not responding, try to consider an agent with a different mechanism of action as a second line agent. That is why in patients in NORAD not improving, we try to add vasopressin. Though the thought process is that probably in sepsis-like state, there is some relative deficiency of vasopressin. As a second line, we add it. Consider adding hydrocortisone, especially in patients on high doses of vasopressors in cases of septic shock. Vasopressin in patients with RV failure is a good option because of the mechanism I told you. Milrinone is this is a patient with hypotension, so obviously you are not going to think about adding milrinone here, even though it's a good pulmonary vasodilator. There is no maximal dose of vasopressors. 40% of the patients have been seen to even receive vasopressors as dose more than 1 microgram per kg per minute. So if I want to summarize the various types of shocks, we know if it is a case of septic shock, if you look at the first line is noradrenaline. When you look at cardiogenic shock, the point of adding this was that if the blood pressure is very low, then noradrenaline would be a better option initially till you make sure that the patient's volume status is adequate. And then maybe you add a dobutamine. Add milrinone only if you have a stable blood pressure. In a case of anaphylactic shock, as I mentioned, adrenaline is the vasopressor of choice. Neurogenic shock, it's noradrenaline. And refractory shocks, we even go up to high dose adrenaline, and then we add vasopressin, and sometimes even phenylephrine also has been added. Now, can we administer vasopressors to peripheral venous catheters? Initially, yes. Early administration of vasopressors you can do, because any delay in achieving an adequate map for the patient can lead to increased mortality. When central venous access cannot be established, so you can start if you're giving at low doses, but the extravasation injuries through a peripheral cath is still acceptable, maybe through a central catheter is not. And how do you the risk of extravasation can you minimize? If you have any doubt, stop the infusion immediately. And when you start that vasopressor infusion through a new access site, try to aspirate it out from the previous catheter and slowly remove the catheter. If there is really some skin changes you are seeing, you can try phentolamine. And in cases if it's a very bad extravasation with necrosis and all, you might even get a surgical evaluation. So there's no harm in starting peripheral vasopressors to peripheral venous catheters. Close watch, and if the doses are increasing, you need to consider a central venous access. So now we'll start with the questions. Dr. Alok, we'll start with the questions.
Yes, sure.
Okay. So I want, you can unmute or you can write in the chat box, whichever. So just randomly, I want to ask. So we talked about receptor. Where does vasopressin act? Anybody can unmute and just tell. You can put it in the chat box. Is anyone replying or?
This session is supposed to be interactive.
Yeah, it's better you tell. It's okay, no problem. You can make mistakes. Nobody's going to judge you over here.
You can type in the chat box if you don't want to unmute and answer the question. Which receptor does vasopressin act on? Okay, so somebody has replied beta 2, but that is incorrect. Vasopressin acts on V1 and V2 receptors. Okay.
So that is what I mentioned. No alpha and beta action, exclusively acts on V1A and V2 receptors. Okay.
Adrenaline.
Yeah.
So anybody can attempt. So we can at least try and answer those questions. Okay. Same person as dobutamine acts on beta 1 receptors. Okay, we're talking about adrenaline. Why does adrenaline act? What receptors? Alpha and beta. Yes, that's right.
Yes. So predominant alpha 1 and beta 1 are very weak beta 2. Now dobutamine.
Okay. So dobutamine is also again goes by the name of the drug itself, D1 and D2 receptors. more of inotropic action.
Very weak alpha 1. Okay. So we move on. So this is a rough chart to show the different drugs acting on the different receptors. So we move on to our next question. So 48-year-old male known smoker has come to your ICU. You are taking the history with your doctor and the patient has no other comorbidities. He actually came with fever and cough with expectoration since 5 days and breathlessness since 1 day. Came to the emergency department and then shifted to your ICU. So when you received the patient's heart rate was 140 per minute, blood pressure was around 90/30, respiratory rate was 38 per minute, and saturation is only 86% in room air. So what do you do with this patient? Such a patient definitely must be coming in all of your ICUs because you're all in IDCCN.
Okay, so yeah, somebody has answered that this patient is in septic shock. Okay. That's right. What do you do immediately for this patient? So,
is the BP alarming for you?
Okay, that's right. Okay, so resuscitation. All right. Okay. So you try to stabilize this patient's vitals. Now, correct. Somebody has answered airway. So you look at all airway, breathing, circulation, and if airway is compromised, secure the airway. Breathing, his saturation is low, isn't it? 86%. So you will start some supplemental oxygen. And because his blood pressure is low, around 90, you will attempt to give some IV fluids and then start NORAD. Isn't it?
Okay. So there's no doctor nearby. This patient has a peripheral IV line. What are you going to do then? This patient requires NORAD.
Okay. So will you or will you not start NORAD for this patient? Okay. So that's a good answer. Okay. So you will start IV fluid bolus, but don't wait for the bolus to get over. Start NORAD through the peripheral line. Meanwhile, you get ready to insert a central line. Okay. So you start both IV fluid bolus and NORAD simultaneously, even through a peripheral line. But keep a watch. QV is one good option. Yes, if you can secure it fast enough.
So now the question 4. So there's a case of old MI with left ventricular failure. EF of 30% has come to your ICU. Patient has cold peripheries. Patient is in pulmonary edema. Patient is also hypotensive. Blood pressure of around 70/50. Right. So what is your drug of choice over here?
We are only talking about vasopressors. Yeah. Okay. Anybody else? All right. Okay, so I think a few people have answered. For most shock states, NORAD is the drug of choice. Okay, so whenever you have hypotension, the material of what the shock is, you can safely say you'll start NORAD. Okay, this is a patient who's got ventricular failure also, and shock is most likely because of an MI. So you will add on another drug to improve the LV function.
Yeah. So So the other part would have been that after giving NORAD, the BP stabilized, but peripheries are still cold, lactate is rising, and urine output is also low. So like Dr. Alok told, you might have to add another drug after making sure your blood pressure is stabilized. What would be that drug?
I think a few of them have. So yeah, in cardiogenic shock, dobutamine. Okay, NORAD along with dobutamine is what you would prefer once the BP improves.
So our last question, a 40-year-old male with massive trauma with blood loss is presented to your ICU, blood pressure of 70/40. What is your drug of choice?
Okay, trauma patient, hypotension, what do you do? Okay. Yeah, okay, we've got a few good answers. Somebody said always give massive amounts of fluid. That may not be right in a trauma patient. Okay, you'll cause a lot of damage. So in this patient, if the patient is in emergency, you will start a massive transfusion protocol, isn't it? That's what you'd want to do. And then simultaneously give not massive amounts of fluid. You will give only about 1 liter of fluid and start NORAD and wait for the blood to come. Okay, because this patient has low BP because he's lost a lot of blood. So give blood. Give blood. You're giving IV fluids only to buy time so your blood can reach your ICU or ER.
So even the NORAD is just to buy you time till you get your blood product. So that the point of putting this question is we have learned about vasopressors inotropes, but along with that, the other management also should continue pertinent to the clinical condition. That's all of the presentation. I'll let Dr. Alok take over.
Okay, so I think it's a very nice class on inotropes and vasopressors. So I think why would anybody want to correct hypotension rapidly? Can anybody tell me that? What happens if you don't correct low blood pressure or hypotension? Okay, so if you don't treat shock immediately, the patient will progress to multiple organ involvement and he will die. So you have to treat hypotension or shock as a medical emergency and treat, yes, venous return arrest, yes, that eventually will happen. But the longer the patient has low blood pressure and is in shock, the more damage you're causing to his organs. His kidneys may shut down, his other organs may get shut down. So you have to act immediately. If you think the patient has lost blood, if you think the patient is in sepsis, start IV fluids and simultaneously start your vasopressors to maintain blood pressure so vital organs will get enough blood flow. Okay, don't wait for your IV fluid bolus to get over to start your vasopressors. Okay, so once you start your IV fluid bolus, simultaneously you can start some low dose of noradrenaline. Noradrenaline is generally the first safest choice for you to start in any shock states. So once you attain the map, you can repeatedly reassess and think about what the cause for shock is and then correct the cause. So Any more questions? Any doubts you have, you can clear. We can clear it for you. You just have to type it in the chat box.
A lot of people have actually answered vasopressin even for cardiogenic shock and hypovolemic, saying that first NORAD and then vasopressin.
So keep saying NORAD, NORAD, NORAD for everything. Don't venture into anything else. First choice is always NORAD for all kinds of shock, be it cardiogenic, be it septic shock, be it hypovolemic shock. Okay. So generally that choice is right. Sometimes if they say anaphylactic and all, adrenaline is the choice because it's a antagonist. Okay, it's the drug of choice for anaphylactic shock patients. Okay, all right. I think there's nothing more to discuss. We'll wait for another few minutes and then wind up. If you have any more questions, you can type it in the chat box. Okay.
We would suggest actually all of you today to, when you go back to your ICU to work, discuss all these drugs with your seniors and doctors over there, so that you get an even better hang of the uses of these drugs in the ICU.
And don't worry about doses, dilutions and all. Most ICUs have protocols in place as to how much you have to dilute, how many ampules you have to dilute. Please go back and check your protocols. Okay, and how to start NORAD, what dose to start. Okay, so you stick to your protocol. What is the choice of fluid for bolus? So in emergency, you can either give normal saline or ringer lactate. Okay, because people say don't crystalloid, NS or RL is completely fine in emergency. You have to give about 1 liter or 2 liters of fluid bolus. We can choose either one of them. But in ICU, most people prefer ringer lactate. Okay, you can use ringer lactate to give IV fluid boluses. Okay. Thank you, Dr. Alisha.
Thank you,
Thank you
Dr.
for the talk. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you.